Welcome back to the deep dive. We're tackling a really critical topic today, based on the material you shared, a true medical emergency.
That's right. We're focusing on toxic epidermal necrolysis, or TEN. Now, for anyone revising, say for the MSRA, this is high-yield stuff. It's severe, it's dramatic, and even though it's rare, you absolutely need to recognize it. It's life-threatening.
Okay.
So our mission here is really to break down the key info,
Yep.
make it clear, make it spick.
Right. Let's dive in then. Toxic epidermal necrolysis. What is it fundamentally?
Okay, so TEN is defined as a severe acute reaction affecting the skin and, crucially, the mucous membranes. Think widespread cell death.
Cell death.
Yeah, necrosis. It causes the outer layer of the skin, the epidermis, to detach from the underlying dermis. And this isn't just a small patch. It can be really extensive over large areas of the body. Plus, the mucous membranes, eyes, mouth, airway, genitals, they're hit too.
Wow.
And like we said, definitely a life-threatening emergency, not just a bad rash.
Okay, that sounds incredibly serious. Skin literally detaching. What sets something like this off? What's the etiology?
So the vast majority of cases, the trigger is a severe adverse drug reaction. It's not a predictable side effect, more like an idiosyncratic hypersensitivity reaction.
Yeah.
Really severe.
Any particular drugs we should, have on our radar?
Yes, definitely. The sources highlight a few key groups. Antibiotics, especially sulphonamides, are high up there.
Okay.
Then you've got anticonvulsants, NSAIDs like your ibuprofen, naproxen, and allopurinol, which is used for gout. Those come up frequently. Antiretrovirals, too, and some others. But those first few are sort of the classic offenders.
Is it always drugs, or can other things trigger tenon?
Drugs are definitely the main culprit, far and away. But the material does mention infections can sometimes be a trigger, though it's less common.
Like what kind of infections?
Things like Mycoplasma pneumonia, the bacterial pneumonia, and certain herpes virus infections are listed as possible non-drug causes.
Okay. So whether it's a drug or maybe an infection, what's actually happening in the body? You mentioned hypersensitivity.
Yeah, the pathophysiology.
Mhm.
It's essentially an immune complex-mediated hypersensitivity reaction. The idea is the body reacts probably to toxic metabolites from processing certain drugs.
Toxic metabolites.
Right, and these metabolites somehow trigger this massive immune response.
Which then attacks the skin.
Exactly. It gets quite cellular. The material mentions cytotoxic T lymphocytes. These are immune cells get activated inappropriately.
Right.
And along with molecules like granzyme B, Facel, and granulosin, they basically attack the keratinocytes.
The main skin cells, you mean?
Precisely, the main cells making up the epidermis.
Mhm.
So you get this huge wave of programmed cell death, necrosis, in those skin cells.
Ah, okay. So the immune system's kind of like attacking the body's own skin structures.
That's a good way to put it. Yeah, the immune system goes haywire and targets the skin and mucous membrane cells, causing them to die off and detach, like the walls crumbling, as we sort of discussed.
Makes sense. Okay, so knowing the triggers and the mechanism, who's more likely to get this? Are there specific risk factors?
There are. The sources list several things. A big one is a history of previous adverse drug reactions. If you've reacted badly before, the risk of a severe reaction like TEN might be higher.
And obviously taking one of those high-risk drugs we mentioned.
Yes, exposure to those specific drug classes is a key risk factor. But beyond that, things like recent immunizations or having had a bone marrow or organ transplant are mentioned. Certain infections, too, like Mycoplasma or HIV, can increase susceptibility.
What about underlying conditions or genetics?
Yeah, both. Conditions like SLE, systemic lupus or erythematosus, and also malignancy are listed as increasing risk. And genetics, definitely. There's specific mention of the HLA-B 502 allele.
HLA-B 502, what's the story there?
Well, this particular genetic variant is found more often in certain ethnic groups, particularly people of East Asian descent. And carrying this allele dramatically increases the risk of TEN if exposed to certain drugs, especially some anticonvulsants like carbamazepine. It really shows how it's often a mix of the trigger, like the drug, and the person's genetic makeup.
That genetic link is crucial, especially for tailoring prescribing, potentially. Okay, so 10 looks dramatic. What else could it be confused with? What are the main differential diagnoses?
Yeah, this is super important because you need to rule things out quickly. Basically, anything causing widespread blisters or skin peeling, the list is quite long.
Go on.
Staphylococcal scalded skin syndrome, SSSS, especially in kids.
Okay.
That's toxin-mediated, though.
Okay.
Burns, obviously chemical, thermal. Bullous impetigo, another skin infection. Then autoimmune blistering diseases like pemphigus or pemphigoid, but the sources say they're usually much slower to develop than 10.
Slower onset, right.
Yeah. Genetic conditions like epidermolysis bullosa, SLE itself can have severe skin manifestations. Scarlet fever is mentioned, but it causes peeling, desquamation. Without the blisters, the bullae, that's a key distinction.
Ah, no belay. Good point.
Other severe drug eruptions, erythema multiforme, which is on the same spectrum, but generally less severe skin detachment, bullous lichen planus, toxic shock syndrome, again, toxin-mediated, and then general widespread redness and peeling conditions like erythroderma. It's a lot to consider.
Definitely need careful assessment. Thankfully, you said it's rare. How rare are we talking?
Very rare, yes.
Yes.
The estimate is about 1 to 2 cases per million people per year globally.
Wow.
It is noted as being a bit more common in older people, possibly just because they tend to be on more medications.
Right. Makes sense.
Hmm.
Okay, so rare but devastating. When you do suspect hien, what does the patient actually look like? How does it typically present?
It often starts quite subtly, which makes early diagnosis tricky. There's usually a prodrome phase, maybe 2 or 3 days, feels like a bad flu.
Flu-like. Okay.
Yeah, fever, maybe some upper respiratory symptoms, sore throat, feeling generally unwell, achy joints and muscles, maybe some itching, and importantly, conjunctivitis red, sore eyes.
So really nonspecific at first?
Exactly. But a key feature, mentioned in about 90% of cases, is early mucous membrane involvement. Sore mouth, sore eyes, genital discomfort, sometimes before the skin rash really kicks off, that's a red flag.
And then the skin changes.
Yes, and it happens fast. A red, painful rash appears, often starting on the face or the upper body, then spreading quickly. Blisters, or bullae, form on these red areas.
Okay.
Then these blisters merge, and the top layer of skin starts to slough off, detach in sheets. It's often described as looking like a severe burn because it's so painful and the skin loss is so extensive.
And how is the patient systemically?
Very unwell, typically running a high fever, hyperpyrexia. They can quickly become dehydrated because of the fluid loss through the damaged skin, leading to low blood pressure, high heart rate. It's like a major burn injury in terms of fluid loss and risk.
Is there that specific sign, Nikolsky's sign?
Yes, positive Nikolsky sign is a classic finding.
Yeah.
If you apply gentle rubbing or sideways pressure on seemingly normal skin near a blistered area, the top layer just shears off. It shows how fragile that epidermal junction is.
Right. Okay, let's try a quick scenario. Say a patient started a new antibiotic a week ago. They felt rough for a couple of days, fever, really sore eyes and mouth. Now they've got this incredibly painful red rash spreading over their chest and back, large blisters forming. And you notice rubbing their arm gently causes the skin to peel right off.
Yeah, that's a textbook picture. The drug exposure, the prodrome, the crucial mucous membrane signs early on, then the rapid, painful, blistering rash, often starting centrally, and that positive Nikolsky's. That pattern screams 10 or SGS-10 spectrum. Needs urgent action.
Absolutely. So high suspicion. What tests do you actually do?
Well, the diagnosis is mainly clinical. It rests heavily on the history, especially that drug history and the physical exam findings. There's no single blood test that says, yes, this is 10.
But you still need labs, right, for management?
Oh, absolutely critical. You need baseline bloods and ongoing monitoring. Full blood count, urea, and electrolytes are vital to track hydration, kidney function. Albumin protein levels can drop significantly. Urine test, too, checking for protein, for instance.
And what about confirming the diagnosis or ruling out those differentials?
Screening for infection is key, so blood, urine, skin cultures. And a skin biopsy can be really helpful. It won't prove 10 on its own, maybe, but it shows that characteristic full-thickness epidermal necrosis and helps differentiate it from things like SSSS or autoimmune blistering diseases.
Okay. And the material mentioned Stevens-Johnson syndrome, SJS, being related.
Yes, SJS and 10 are viewed as the same disease process, just on a spectrum of severity. The distinction is made based on the percentage of body surface area, the BSA, that has skin detachment.
Right.
The sources don't specify the exact cutoffs here, but basically, less detachment is SJS, more extensive detachment pushes it into SJS-10 overlap, or full-blown 10.
Got it. So clinical diagnosis, supportive tests, how do we manage it? What's the approach, say, in the UK?
Management is all about speed and intensity. First step, immediate hospital admission, ideally straight to a specialized unit.
Like a burns unit.
Exactly, a burns unit or maybe a dermatology ICU if available. They have the expertise in managing large areas of skin loss and critical illness.
And the absolute first thing you do?
Stop the suspected causative drug immediately. That's priority number 1. Then it's all about intensive supportive care and preventing complications, especially infection. This is ICU-level care.
Is there anything pharmacologically to, like, stop the reaction itself?
This is where it gets a bit controversial, according to the sources. Intravenous immunoglobulin, IVI, is mentioned as a first-line pharmacological option.
Okay, IVI. Anything else?
Other drugs like cyclosporin, maybe cyclophosphamide, are mentioned, but importantly, the material highlights that systemic steroids, IVI, cyclosporin, even TNF-alpha inhibitors, they're all still considered controversial treatments.
Ah, okay. So no magic bullet drug.
Not really a universally agreed one. While things like plasmapheresis or drugs like infliximab or etanercept have been considered or used, there's a lack of definitive evidence from large trials. So the cornerstone remains stopping the trigger and aggressive supportive care.
Right. Tell me more about that supportive care. What does it actually involve?
It's incredibly detailed, very similar to managing major burns. You've got massive fluid loss, so meticulous fluid and electrolyte replacement is vital. Infection control is huge. That lost skin barrier means a massive risk of sepsis, so barrier nursing, careful monitoring, maybe prophylactic antibiotics, so that's also debated.
And nutrition and skincare.
Yeah, nutritional support is key, often needing tube feeding if the mouth is badly affected. And the skincare is intensive, gentle cleaning, maybe some debridement of dead skin, special non-adherent dressings, emollients, trying to prevent shearing forces on the fragile healing skin. It takes a whole multidisciplinary team.
Sounds incredibly challenging. Given all that, what's the outlook? What's the prognosis?
It's serious. Tin has a high mortality rate. The outcome really depends on factors like how much skin it's involved, the BSA, the patient's age, any other underlying health problems, and crucially, how quickly they get to that specialized care.
Is there a way to quantify that risk?
Yes, the Scorton scale is used for exactly that. It predicts mortality risk based on several clinical factors. The measures are quite sobering.
How sobering?
A score of 0-1 gives about a 3% mortality risk. Score 2, it jumps to 12%. Score 3 is over 35%. Score 4 is nearly 60%. And if the score is 5 or more, the mortality risk is estimated at 90%.
Wow. That really brings home the severity.
It does.
And for those who do survive, are there lasting effects?
Yes, definitely. Surviving the acute phase is often just the beginning. Long-term complications are common and absolutely vital. Survivors must avoid the offending drug forever, and it needs to be clearly documented everywhere in their records.
What sort of long-term problems are we talking about?
They can be really widespread because it hits mucous membranes too. In the acute phase, besides sepsis, you worry about pneumonia, respiratory failure, dehydration, shock, organ failure, blood clots.
Right, the immediate dangers. But long-term?
Long-term, eye problems are a major concern. Severe dry eyes, scarring, even blindness, joint contractures from immobility, nail loss or abnormalities, persistent mouth problems, swallowing difficulties from esophageal strictures, GI bleeding, genital issues like phimosis in men or gynecological problems.
And the skin itself, does it heal okay?
Often it heals with pigment changes, patches of lighter or darker skin. Scarring can happen, especially if there was infection. Increased sun sensitivity is common. And of course, there's the huge psychological toll of having gone through something so traumatic.
It really is a devastating condition, top to bottom.
Absolutely. This deep dive really underlines that 10, while rare, demands immediate recognition, stopping the drug, and getting the patient to intensive specialist supportive care. The potential for severe complications, both immediate and long-term, just highlights why being vigilant about drug reactions and recognizing those early signs is so vital.
A really important overview. Thank you for walking us through that complex picture so clearly.
Happy to help. It's crucial information.
And thank you for tuning into this deep dive. For more free MSRA revision resources, you can visit freemsra.com. And for the full premium revision toolkit, check out passthroughmsra.com.